So this patient was in today, and she's got a tooth number 14 that's part of a long span bridge that's been there for a number of years, and it's got non-restorable decay. So I wanted to investigate the possibility of putting in 2 implants, and what are the chances that I might need to have a sinus bump or a sinus lift once I get beyond extraction and grafting. So I decided to get a cone beam CBCT and STL files, upper arch scans, intraoral scans, and begin to evaluate the site. So kind of looking at the area of interest now, it's in the 13 to 14 area. There's a ponic at 13. We want to put implants at 13 and 14. So I kind of want to get an idea of what I think might happen after the graft. Will I need to have a sinus lift, so that I can include that in her treatment schedule that I want to create for her? Because my ultimate goal is to get a treatment schedule that is thorough and complete, that I can present to her so that she can accept treatment. So here we're stitching the STL file, checking the alignment across the arch. And it looks like it aligns well to the patient's anatomy. And so we're going to go ahead and just begin by putting a couple implants in. I find the easiest way to determine if you have enough bone width or whatnot is just drop a couple implants in, and I'll put a couple of plan abutments on just so I can see the projections of the implants. In this case, I'm using her full arch intraoral scan as sort of my diagnostic wax up, because that's where I want the teeth to be. I want the teeth to be exactly where they're located now. So we're putting in the first implant in the number 13 site, just kind of grossly aligning it, adding in abutment so I can see the projection. And this will sort of mimic your pilot drill, if you will. 16 millimeters tall and 2 millimeters in diameter. But with this, you can see exactly where the implant lines up within the bone, and you can follow the projection through the prosthetic. Of course, her natural teeth, where they're located now, is my prosthetic projection, or wax up, if you will. And so that's what I want to align to. We'll go ahead and deal with the validation error that I'm getting. It's very commonly, I place biohorizon implants, and I use a protocol using the custom kit, so that I use biohorizon sleeves, whatnot. It's just my own personal preference. So if I turn off get the custom kit on the screen, and also turn off the guide tube violation, I know that my guide tube is going to touch the STL file in this case. So doing those things fixes the validation error. And I can proceed with aligning. I can just see it more clearly when I don't have those validation errors in the way. So now we're duplicating that implant. It'll duplicate the abutment as well, and just duplicate it and sliding it into a position. I can begin to see what the second implant's going to project like. So I'm starting to see that as long as I get a decent socket graft, that I can probably place 2 implants with just a very small bump. So I don't have to be thinking lateral window necessarily in this particular case. And then eventually I'll take all this information into Excel and produce the treatment schedule that I need. Now, the purpose of going through this is not to create a surgical guide. I do not intend to place these implants in an immediate fashion. I'm going to extract and graft the number 14 site, develop my site, and then come back at a later date and place the 2 implants, and then of course restore them. I will have a discussion with her about a provisional for this case. Some patients might be willing to not have a provisional in this particular case. However, this particular lady, very active in her church and does a lot of reading from the podium and whatnot, and on camera today with online social distancing practices. So she's concerned about it. So we will probably end up making her an Essex type of a provisional that she can wear when she needs to for aesthetic concerns. So you can see I've got 2 implants. It'll be small bumps that should be easy to accomplish at the time of surgery. So now I'm going to take that information over to Excel and do my treatment planning in Excel. Because my ultimate goal is to produce a very thorough, concise timeline of events that it takes to go from where she is now to 2 implants that also shows what the fees will be and when she has to pay it. We're going to start in Excel by developing a treatment estimate. This treatment estimate lists the various things that she needs, only the things she needs. So I can go into my template and delete items that do not really apply to her particular case, and add tooth numbers, etc. for things that do apply, and set the count number correctly for things that do apply. And it will begin to develop a fee for this case just based upon the things she needs and the numbers of the different line items. So we're adjusting the various items, putting in the things that we don't, putting in the things that we do need, and removing lines that we don't need until we get everything that we can think of that we need to do in order to facilitate this case from start to finish. Excel is very efficient at gathering and storing information and displaying information, and also adding up numbers and such. The trick is just knowing how to work with this particular software so that you can make it do what you want it to do. We could easily spend a couple of days going over this to get you proficient at how to handling Excel. But once you do that, it can pay some great rewards in the long run. So we're just taking the information from our data collection, which in this case is a CBCT and clinical exam, and putting it into a logical format that I can present to a patient. This is really all about manipulating the software. A few things you have to learn in Excel so that you can navigate and make the presentation look the way that you want it to look. We're making sure our last column adds up and is adding up all of the numbers in that last column. So we have a complete treatment plan total. Adjusting the numbers of items so that the total is complete. And now we will copy and paste this information from the treatment estimate over to the treatment schedule. Now this is the form where we are actually creating the document that we'll show to the patient. The treatment estimate is just a tally of the different types of things and numbers of things we need in order to complete the treatment plan, whereas this is more listed in logical order, sequencing it for the patient so that we have something concise to present to them. So we're going to insert some blank spaces and move things into a logical order of what we're going to do first, second, third, all the way through to the end. And this is in the order that they should appear or that they should be completed. Still putting things in logical order, taking out lines that we don't need. Once we get the Excel sheet where it's in logical order, we now want to go to your practice management software and enter all the treatment in the practice management software, and we make sure that the treatment plan in the practice management software, that the fee equals the fee that we have that we're going to present to the patient. Because ultimately your practice management software is what's doing the billing and managing the financial information for the patient. Various practice management softwares do things a little differently, but they all do basically the same function. You can completely treatment plan in the practice management software and make sure the two numbers agree. Where Excel has an advantage over the practice management software is the wording that you can put with each procedure. because each patient's treatment plan is quite unique, and you can put enough words in the descriptions that maintain logical flow throughout these long treatment plans. These treatment plans easily go 6, 8, 10 months or even longer, and it's difficult or maybe even impossible to keep the logic straight with the type of treatment plans you get out of the practice management softwares. They are basically line items. They're essentially a treatment estimate that we created in Excel. It's just a bunch of line items with the numbers of procedures. Yes, you can group things in group order, but you can't put in notes about why you're doing exactly what you're doing. And it also makes absolutely no sense to a patient. So we want to create something in Excel that we can present to the patient, and it maintains our logical flow throughout the length of the treatment plan. So we're just entering the treatment plan into the practice management software, and we're going to make sure that the two numbers agree. Be very, very cautious that the two numbers always agree. And even going forward, as you begin treating the patient, when the logic changes, something changes in the plan, we're going to go back and make sure that the practice management software stays in agreement throughout the time that the patient is in treatment. So we can just flip back between Excel and the practice management software, making sure everything matches and agrees. Once we get it to the point where the two numbers match, then we're ready to finish our treatment schedule in Excel. So I see here that we have a couple of fees that I have adjusted based upon the difficulty of this procedure. I've increased the fee just a little bit, and so we want to go into the practice management software and correct that fee so that it matches Excel. And so that's what we're doing here, is we're just adjusting the line item fee to match what my logical plan is dictating. Okay, I think now we'll find that the two numbers agree. And we can go into Excel, develop the timeline and the payment schedule, get it to print on one page, and then we're done. So we're developing the timeline. Timeline is all done with formulas to count days. So from the time of the consultation, I generally add maybe a week or two, depending upon the case, to determine when the first step will start. And then we continue to add formulas. We're going to add from implant placement to uncovery, either 90 or 120 days, 3 or 4 months, depending upon the case at hand. Between implant uncovery and impression, I generally add 3 weeks. And as you go down through, you'll develop a timeline that shows exactly when, shows relatively when the patient will finish the treatment. I tell patients this is not a firm timeline, that this is something that will be modified and adjusted as we go through her plan, and we're not locked into any of these dates. And I don't want them to focus on the dates either, other than a general idea of how long it will take to finish this plan. We have certain limitations as to how fast we can go based upon healing, osseointegration, various things of that sort, and lab time, etc. So we're developing the timeline such that the patient will get a very clear idea that this treatment plan will not happen in 1-2 weeks or even a month or two. Later, when we're doing the treatment schedule, there's an additional benefit that the patient will be able to see very clearly that while the fee may be large for a big case, for any particular case, the fee may be large, the patient will see very clearly that they have a timeline over which to pay for the treatment. It has a very profound effect on their ability to accept treatment. The psychology behind this approach, as it has worked out, seems to be pretty impressive as far as being able to get patients to accept treatment. Not that I knew that when I began developing this technique, but it has just worked out that way over time. Here again, learning formulas and learning how to do this calculations is a small learning curve, but in a matter of a day's time, working with Excel with in a small class format, you can master these skills quite easily. All of my staff know how to work Excel. We actually dictate the examination on the fly. They type it all in. They manage the data, and then I, of course, do the treatment schedules in my after hours time. Generally speaking, this level of treatment planning is not done during patient time. It's done after hours. So I'm developing a payment schedule now that kind of keeps the patient paid ahead. I'd rather them stay ahead of the game with their payment schedule. That way we don't have financial issues that cause us problems. And then, generally speaking, there's a small payment toward the end. So the strategy varies from patient to patient as to how you want to build the payment schedule. And even once you present it to the patient, if they want to modify it somewhat, there is latitude doing that. You just have to go in and think about what are they asking to do, and does that work with your philosophy on how you want to be paid. So we're kind of grouping items together along through the timeline and making sure that the total of the payment schedule equals the total of the planned treatment. And of course you do that by just adjusting the formulas and whatnot. So here we are adjusting the formula for the total so that we can see that the total of the payment schedule matches the total of the plan. A 5% discount will make a big difference in a patient accepting treatment. We routinely offer a 5% discount for cash or check when a patient is having a comprehensive plan. It's a big motivator. Patients want to know that they're getting a very fair deal, a reasonable cost. A discount is always appreciated. So now we want to get it to print on one page. We will use the print preview feature to show what it's going to look like when it's printed. And you can see it's too wide. We're losing the right-hand column with the payment schedule information. You can see the second page shows that the last part of the width is printing on the second page. So we'll just go back into Excel and adjust the column widths a little bit. Now you see this little dotted line that indicates where the page is being cut off at. And by adjusting the width of these columns, we can get that little dotted line to go away, and that will make the page print on one page. You can see now it prints on one page. This will make a nice, clear, concise presentation for the patient. They can understand the language that's written on the form. They can see the timeline. They can see the payment schedule, and it makes them very easily understand what you're proposing and creates a good conversation. And when a patient understands what they're about to do, they have no problem committing to the treatment plan. Hope this helps. We'll talk to you soon. Hey, thank you for watching. I hope this has been beneficial. If you have questions or comments, you can email me at drp@drpatedmd.com. I love to teach courses at my office from time to time. These are boutique type courses limited to 10 to 12 participants at most. My passions are guided surgery, data collection and case presentation for the new patient exam. We utilize Excel to organize and streamline the data collection, and then PowerPoint to illustrate the treatment, customizing the presentation using the patient photos obtained during data collection. I also love to discuss digital diagnosis using Exicad. Wow, that's a big topic, but so much fun. If you're interested in any of these topics, I'd love to hear from you, and we can try to set up some time to get you up to speed on your topic of interest. Now, these courses are software intense. I find the biggest roadblock most dentists have to digital dentistry and guided surgery is learning to use the software. So we dive deeply into the software so that you learn the fine points of the digital world. We can initially outsource the 3D printing, and once you know the software, in-office 3D printing is easy to add. We can plan one-day classes, but the most benefit is obtained from at least a 2-day format with any of these topics to become proficient. Have a great day in spite of all this COVID shutdown, and I hope to hear from you soon.